Physicians are drowning in a chaotic, unsynthesized volume of patient data. Modern hospitals operate within silos of disconnected local databases and contradictory protocols. This fragmentation pushes a clinician's cognitive load to the breaking point, creating an environment prone to missed drug interactions and overlooked diagnostic clues. Raw data functions as a systemic liability, providing a space where fatal errors remain invisible to the naked eye. Bridging this gap requires an active clinical integration layer, a system that processes information in real time rather than sitting as a static archive. This architecture acts as a cognitive partner, cross-referencing live inputs against global protocols as the doctor works. This technology tames chaotic data into clean, actionable intelligence, supporting human decision-making with a unified evidence base. This chart tracks a 21-day relationship between physician Jana and AI's ZDRAVKO. Spikes show 7 medical cases they tackled. During their first case, a suspected migraine, the AI flagged an orange threat for subarachnoid hemorrhage. Jana manually downgraded it to yellow. The AI instantly revised its differential diagnosis. Accepting the correction without defensiveness, it generated a targeted treatment plan aligning with Jana's expertise. Medical AI builds trust by functioning as a collaborative junior colleague, yielding to clinical experience to refine its own logic. On day 11, the collaboration faced a complex challenge. A colleague had been exposed to secondary syphilis while working without gloves. The risk profile changed significantly because the exposed colleague was on Cosentyx. Cosentyx is an immunosuppressant biological therapy that inhibits a specific protein involved in inflammation. This risk matrix illustrates the AI's reaction. Identifying the drug-disease interaction, it immediately escalated its threat assessment. The system then mapped the mechanism. Cosentyx suppresses antimicrobial peptides, reducing mucocutaneous defenses, making the body highly vulnerable to infection. The AI alerted Jana to a specific conflict, the colleague's underlying psoriatic arthritis. In an immunosuppressed patient, the rash associated with syphilis can look nearly identical to a routine psoriasis flare-up. To manage the exposure, the AI cited protocols from the CDC and the British Association for Sexual Health and HIV to set a precise 90-day window for prophylactic treatment. Clinical intelligence relies on this level of synthesis, connecting pharmacology, immunology, and patient history to identify risks before they manifest. This split screen shows a historical Doppler ultrasound compared to a current diagnosis of deep vein thrombosis, or DVT. DVT is a blood clot in a deep vein, and a Doppler ultrasound is an imaging test that measures blood flow. When Jana's father was diagnosed with a DVT, she feared she had missed the signs during an exam 2 months earlier. Rather than offering generic platitudes about the difficulty of care, the AI addressed Jana's guilt with a rigorous data review. The system reconstructed the clinical timeline, showing that the recent clot resulted from a localized skin infection called cellulitis just 4 days prior. The anatomical evidence proved the earlier Doppler report was correct. In medicine, evidence-based validation provides the most effective form of professional support, confirming the accuracy of a physician's past decisions. The ultimate metric for medical AI is user retention, how often a physician chooses to return to the system. Jana's logs provide the proof of success. She returned to the system 7 times in 3 weeks, bringing increasingly complex and personal challenges to the platform. Her behavior indicates a paradigm shift. The software has evolved from a simple search tool into a tireless clinical peer. Integrating medical data eliminates the systemic blind spots of modern healthcare, freeing the physician to focus entirely on the patient.